Hello everyone, I am going to present about genital infection. Let's go with the topic. So in the genito-urinary infection, I have divided it into three types: vaginitis, cervicitis and pelvic inflammatory diseases. In vaginitis, there are bacterial vaginosis, candidiasis, trichomoniasis, and in cervicitis there is chlamydia, gonorrhea and pelvic inflammatory disease. So first we have to understand that the normal vaginal defense, like why there is no any infection in the normal condition, because there is like stratified squamous epithelium lining around the vagina, so that it is also one of the protective barrier, and there is acidic pH, so that many microorganisms cannot grow there easily, so that they cannot grow. So it acts as normal vaginal defense. There is the pH of 3.5 to 4.5, and why this pH is maintained is because due to the estrogen. So how estrogen increases the increases the pH or acid, how it maintains the acidic pH in the vaginal lining is that due to like estrogen increases glycogen synthesis in vaginal epithelial cell, and then the glycogen is utilized by the lactobacilli, which is generally present there, and it releases lactic acid. So in the prepubertal, postmenopausal and the women in the menses have pH 6 to 8, not like acidic pH, so they are more susceptible for the infection or genitourinary infection in that period, because the pH increases at that time, and infection can occur in that time. So let's go to the vaginitis. The first is bacterial vaginosis. It is most common cause of vaginitis, and there is abnormal growth of vaginal flora in the bacterial vaginosis. So, and I have already told that lactobacillus is generally present there, and it is replaced by the gram-negative rods. And the major organism which is causing the bacterial vaginosis are Gardnerella vaginalis, Mycoplasma, Ureaplasma and Moveluncus. So for the diagnosis, there is Amsel's criteria. For the in the Amsel criteria, it has given 4 criteria. If 3 meet the condition, then we can diagnose it as bacterial vaginosis. So foul smelling discharge, pH greater than 4.5, wet smell, fluid cells are seen, and whiff test or amide test is positive, then the bacterial vaginosis is proved. And like treatment of choice in bacterial vaginosis is mainly it is given metronidazole, and sometimes clindamycin can also be used in bacterial vaginosis. So next is Candidiasis. Most common organism which is causing Candidiasis is Candida albicans, and the predisposing factor, like when there is immunocompromise, then the Candidiasis infection or Candida infection occurring there, and antibiotic using patient, pregnant patient and the diabetes patient are more susceptible, or it is the predisposing factor for the Candidiasis. So the feature are like cloudy white vaginal discharge, like cottage cheese discharge can be seen in the Candidiasis, and itching, dysuria and splash dysuria, like when there is itching and there will be rupture of the skin, and then when urination occur, then there will be the pain. So this itching and dysuria is commonly seen, and like vaginal pH is like Candida can grow in acidic pH also, so it can also grow in less than 4.5 or normal vaginal pH. So we can also find Candidiasis in normal vaginal pH, and investigation of choice is like wet smear, which shows fungal hyphae, and treatment is fluconazole. So next is Trichomoniasis. Organism responsible is Trichomonas vaginalis, and it is transmitted sexually. And for the characteristic, like greenish thin for the discharge is occurring there, pruritus, dysuria, vaginal pH is greater than 4.5, and shows strawberry cervix. When we look for the cervix, like strawberry like cervix can be seen in the examination. And investigation of choice is wet smear, and WBC is present, and tennis racket appearance can be seen in the investigation, and treatment is metronidazole. So next is cervicitis. So we have completed vaginitis. Then let's go to the cervicitis. Mainly two organisms lodged there, like in the endocervix, are chlamydia and gonorrhea. So let's talk about chlamydia. 80% of infections are asymptomatic. The most important thing is that 80% of the infection are asymptomatic, and gram stent, when we do the gram stent, there is no organism seen. Why we do gram stent if there is no organism seen is that to differentiate like chlamydia and gonorrhea. In the gonorrhea, which we will talk in the next slide, that there will be organism seen, but there is no any organism seen in the gram stent. And investigation of choice is NAATS, like nucleic acid amplification test, and there is like for the culture MC cell line culture must be done. It is gold standard, and treatment is azithromycin and doxycycline can be used for cervicitis. So like next is gonorrhea. It is like in the chlamydia 80% are asymptomatic. Here is 50% are asymptomatic, and as I have talked earlier also, as gram stent shows WBC present in the chlamydia also, but here is gram negative intracellular diplococci present in gonorrhea, but there is no organism found in the chlamydia, so we can differentiate it, and the culture is done, and the treatment is ceftriaxone and azithromycin is given. So when we treat the gonorrhea, we have to also treat the chlamydia, because chlamydia, as we have already talked about, it is 80% are asymptomatic. So if there is gonorrhea is present in the patient, there is high chance that chlamydia is also present. So when we treat gonorrhea, we also have to treat chlamydia also. So as this is the theory portion we have talked about, so how we manage like syndromic approach for this treatment, like as we have talked about, when women come with the discharge for vaginum, so we have to ask for character of discharge, associated symptom like itching, and urinary symptom, burning, dysuria, and partner history is also important to ask when the discharge per vaginum discharge of the woman present to the OPD. So after asking this, we have to do the per speculum examination. So in the per speculum examination, if we see the cervix is healthy and discharge which is coming from the vagina, then we can suspect of the vaginitis. But if the discharge coming out from the os and the cervix is unhealthy and there is a cervical erosion seen and cervix bleed on touch, when we touch the cervix then it bleeds, then we can suspect that it is suggestive of cervicitis. So let's go to the vaginitis. Like if cervix is healthy and discharge from the vagina, if we suspect the vaginitis, then what should we do? So if it is vaginitis, as we have talked about earlier also, weight smear must be done or should be done for the vaginitis. So three things we have already talked, like bacterial vaginosis, candidiasis, and trichomonasis are present in the vaginitis. So if we see the clue cells, as we have already talked earlier also, in the bacterial vaginosis, like M cells criteria, like if in the weight smear clue cell are seen, then we can suspect that it is bacterial vaginosis. If the fungal hyphae like Candidiasis, fungal hyphae is seen, then we can suspect the Candidiasis. And if the flagellated organism is seen, we can suspect the trichomonasis. So if in the OPD or in the hospital setting or the health setting, if there is no any weight smear we cannot do, then we have to treat the vaginitis, but the organism which is causing the vaginitis is not known, so we have to treat fully. So for fully treatment, like if we have clue cells, then we can give metronidazole. If the flagellated organism, we can give metronidazole, and if fungal hyphae, we can give fluconazole. But if there is no any test or like weight smear there, then we have to treat all these. So fluconazole oral single dose 150 mg must be given, with the secnidazole 2 gram oral single dose must be given in the vaginitis, if we have to treat all three. So in the cervicitis, So we have to do the gram stain of the discharge. If the gram stain, as we have already talked, WBC present but no organism seen, then we have to suspect or presumptive diagnosis is chlamydia. If the WBC present and gram negative intercellular diplococci is seen, then presumptive diagnosis of gonorrhea. So the drugs we have to give is ceftriaxone 250 mg intramuscular single dose, or tablet cefixime single dose, and tablet azithromycin 1 gram oral single dose must be given. So in the cervicitis, like if these organisms are there, we have to treat the partner also. Partner treatment is also required, and we have to tell the patient to avoid the intercourse for 7 days, and we should also provide condoms to the patients. Okay. Then the next is like we have completed cervicitis. Next is pelvic inflammatory disease. It is the upper genital tract infection causing endometritis, salpingitis, oophorytis, and pelvic peritonitis. Like upper genital tract infection like endometritis, salpingitis, like fallopian tube infection, like inflammation, oophorytis, pelvic peritonitis, and it is ascending infection from the endocervix, and most common cause of the pelvic inflammatory disease is chlamydia. And in pelvic inflammatory disease in virgin female, the most common cause is tuberculosis, as systemic root, it comes from the systemic root, and in postmenopausal women, most common cause is E. coli, which is causing PID. So clinical feature of PID are pelvic pain, vaginal discharge, dysuria, fever, mostly seen in acute PID, and menorrhagia, not much common but can also be seen. So there can be the swollen fallopian tube, like if there is presence of water or accumulation of water hydrosulfings, and if there is accumulation of pus, pyosulfings can be occurring. So for the diagnosis of PID, minimum criteria are like physical examination, which we have already talked, like, and there is cervical muscle tenderness, adnexal tenderness, and uterine tenderness is must be done. And for the additional criteria like fever, mucopurulent cervicitis, leukocytosis, cervical discharge positive for chlamydia, gonorrhea can be done in additional criteria. For the diagnosis, like definitive diagnosis, USC showing tube ovarian mass, endometritis on endometrial biopsy, laparoscopy evidence shows the definitive diagnosis of PID. So there is one syndrome called Fitz-Hughes-Curtis syndrome. What syndrome is that? Chronic manifestation of pelvic inflammatory disease, described as inflammation of liver capsule without the involvement of liver parenchyma. Like it is the chronic manifestation of PID. It is called as Fitz-Hughes-Curtis syndrome, FHCS. Okay. So what is the systemic approach for the treatment? Like women with the complaint of acute severe pelvic pain and dysuria with fever, diarrhea, and severe vomiting. Then the physical examination shows that lower abdominal tenderness, uterus size normal but tender, tenderness of vaginal furnaces, tenderness adnexal mass. So if there is a suspicion of peritonitis and the patient is too sick, or the pregnant woman, then we have to admit the patient. But if this condition do not fulfill, then we give the medicine and send to the home. But if this condition, like the feature of peritonitis, like lower abdominal tenderness is seen, then we have to put the patient or have inpatient treatment. We should have to do inpatient treatment. For the drug cefixime 2 gram intravenous 6 hourly must be given, and capsule doxycycline 100 mg BD, and tablet metronidazole 500 mg BD. Total 14 days given intravenously, as cefixime 6 mg intravenously given. And after the after 2 to 3 days, if the condition improves, then we can change to the oral drugs also. So next is torch infection. Torch infection is mainly important in the pregnant woman because of like the fetal, it causes more effect to the fetus. So TORCH infection is like toxoplasmosis, so caused by the Toxoplasma gondii, obligate intracellular protozoonitis. So life cycle of it is like definitive host is cat. So when the cat's oocyst like in the feces, it is on its sporulary oocyst and it becomes sporulary oocyst and goes to the food, water and soil, and it is taken by the different animal, and then the tissue cyst ingested by the definitive host, and this cycle occurs. So infection of man can be due to the eating raw undercooked meat, and cyst can be ingested, and contact with the fetus like contact with the cat feces. So the oocyst can go, and contaminated food, water can be source of the infection in the man. So for the toxoplasmosis, like in the human infection, mostly subclinical, like toxoplasmosis infection are mostly subclinical. There is fatigue, fever, headache, maculopapular rash, posterior cervical lymphadenopathy, encephalopathy, and retinitis and choroiditis can be seen. And infection lead to lifelong immunity. If one time there is infection occurring in the woman or the patient, then it gives lifelong immunity. And infection during pregnancy causes risks to fetus, and risks for the vertical transmission increases with gestational age. And if fetus infected in first trimester, then the severe form of the toxoplasmosis can be seen. So what are the features of the congenital toxoplasmosis? Are that these three are the triad hydrocephalus, chorioretinitis, and intracranial calcification, mainly paraventricular, and generalized calcification are seen. So these are the triad of the congenital toxoplasmosis. And low birth weight, hepatosplenomegaly, jaundice, anemia, learning disability, and convulsion. These are also the feature of toxoplasmosis. So what are the syndromic approach for the treatment? So pregnant and women suspected of toxoplasmosis. So pregnant women suspected of toxoplasmosis in the first trimester, and then we have to do the serological testing. So in the serological testing, if the IgM is negative and IgG is positive, then it is past infection, so we do not have to worry much about that. And if the IgM is positive and IgG is also positive, so we have to do the IgG test, like it is high avidity or low avidity. If it is high avidity, it is greater than 4 months infection, so it is done first trimester, so there is no any risk. So if there is low avidity, then it is recent infection, so prenatal diagnosis of fetal infection must be done. And spiramycin is also have to give to the mother to decrease the vertical transmission of this disease. And as like fetal immunosynthesis have done, then fetal infection confirmed by PCR analysis of amniotic fluid, and USC, fetal USC can also be done, which suggests of toxoplasmosis. So we have to give pyrimethamine and sulfadiazine treatment. So it is given to the mother, and it crosses the placenta for treatment of congenital toxoplasmosis, which is occurring in the fetus. So next is Rubella virus. So it is RNA togavirus. It is like transmitted contact with the infected person and transmitted via nasopharyngeal secretion, and infected and then it infects the pregnant woman. So maternal rubella is mostly asymptomatic, and if there is symptom like mild fever, maculopapular rash, cervical lymphadenopathy can be seen. And fetal infection with rubella is like first if maternal infection is first 12 week, then congenital infection is 90% of the cases. So if the infection occur in early period, then there is chance of more defect, and defect are rare after 20 weeks if there is infection happening after 20 weeks. So the triad feature of the rubella are deafness, patent ductus arteriosus, and cataract are the triad feature of the rubella. And other are neurodevelopmental delay, microphthalmia, thrombocytes purpura rash, and diabetes, ventriculomegaly, microcephaly, intracranial calcification, hepatosplenomegaly, fetal growth restriction, and fetal hydro. So prevention of the rubella, then we have to, there is a vaccine like MMR vaccine is recommended for non-pregnant women, and in the pregnancy avoided at least 1 month after the vaccination. If the non-pregnant women take the vaccination, we have to avoid the pregnancy for 1 month after vaccination. So why it is that we have to avoid 1 month after vaccination is that there is feature of the rubella like syndrome occurring in the mother, and also there is also chance of transmission. So we have to avoid at least 1 month after vaccination. And in preconception counseling, we have to ask for vaccination status, as she has taken MMR vaccine or not. If she is not vaccinated, then we have to do the anti-IgG for rubella. So next is Cytomegalovirus. It is done by the it is causes by the DNA herpes virus, and reactivation can occur in this virus, and mild clinical flu-like illness, mostly asymptomatic, and no lifelong immunity occurring. If one time infected, then there is no lifelong immunity, only partial immunity is there, so reinfection can occur in the patient. So for the spread, how it is spread, like it can be excreted in all body fluid and person to person contact, then it is spread. And most common perinatal infection and most common cause is by vertical transmission as placental transmission, and maximum risk of transmission is in 3rd trimester. So clinical features are microcephaly, chorioretinitis, periventricular calcification, fetal growth restriction, jaundice, petechial hemorrhage, like blueberry muffin rash can also be seen, and hepatosplenomegaly. And long-term sequelae are of congenital CMV infection, like in the long term, like mental retardation. It is the most common infective cause of mental retardation in children. So and motor and sensory deficit, and vision loss, and sensorineural hearing loss. It is also most common infective cause of sensorineural hearing loss in childhood is this CMV infection, cytomegalovirus infection. So next is herpes simplex virus. DNA, it is caused by DNA herpes virus and transmitted by direct contact, ulcer, mucocutaneous lesion. There are two, HSP1 and HSP2, mostly non-stop genital infection, and typically acquired in childhood. So in HSP2, mostly genital infection and acquired through sexual contact. Okay, 90% of the primary infection are asymptomatic. So direct contact with the person with herpes, like lesion of herpes, then virus travel along sensory nerves, and then it become latent in the cranial nerve or dorsal nerve ganglia, and reoccurrence are common, and HSV2 are more common in recurrence and must happen within the first year of the primary infection. These recurrence are occur. And the clinical features are multiple vesicular lesions, painful itching and tingling, later ulcerate the lesions, and inguinal lymphadenopathy. Incubation period are 6 to 8 days, and laboratory confirmation for diagnosis is like specimen from the lesion, and then DNA PCR testing is done, and serological test like IgG against HSP1 and HSP2 is done. So first episode, like it is also primary infection. HSV can be isolated from the lesion, but no antibody against HSV in the serum can be found in the primary infection. But in the recurrent infection, HSV lesion is seen in the lesion. Also, same HSV type antibody is also serum, so we can distinguish between primary and recurrent infection. Partner testing is also should be done in this condition. So when the pregnant woman with the primary genital herpes and the pregnant woman with a history of genital herpes with recurrent lesion comes to the OPD, then we have to treat the episode. For the treatment of the episode, the drug which we use is for the primary or first episode infection, acyclovir must be or can be given, and for the asymptomatic recurrent infection there is also given of acyclovir, but it is given for 7 to 10 days, but it is given for 5 days. And there is also daily suppression like acyclovir is given from the 36 week until delivery. So that decrease peripartum viral shedding, and the suppressive therapy from the 36 weeks onward, like it decreases the risk of recurrence, and it is given in the pregnant woman after or from the 36 week until delivery. So when there is active genital tract lesion or prodromal symptom in labor, then we have to do the cesarean delivery. And if there is no active lesion during the labor, then we can also do the vaginal delivery, and we have to avoid unnecessary invasive procedure. And if there is no any active breast lesion, we can continue breastfeeding. So the reference, and thank you.